Maybe Jan, if you can stop to share your screen or...
Do I share it already or?
Okay, no.
Sorry.
So I will start. Dear colleagues, dear friends, it's my pleasure to welcome you again for this new ENS skill-based section webinar dedicated to another aspect of our procedure, which is the Telovelar approach, a very interesting approach that is very interesting to use for such dedicated access by sample for foreventricular tumors. And today we have still a fantastic panel of speakers. We will start first with a talk of Eckhard Casper and Jan Frederick Cornelius. Eckhard Casper worked in University and will discuss about the versatility of the Telovelar approach for lesions of the posterior fossa. And then, in agreement with Jan Frederick Cornelius, they will discuss about very specific cases, but maybe more at the end of the webinar. We will have the chance to listen to Henri Schroeder, well known. Thank you, Henri, to be with us every month, I will say. And it will be very interesting to listen to your experience for this approach for ependymomas of the fourth ventricle. And then finally, it's a pleasure to welcome a new member, a new panelist working with Marcos Tatagiba team in Tübingen. Professor Martin Schumann will discuss with us this approach, this Telovelar approach to fourth ventricle lesions, specifically for pediatric tumors. So thank you again to be with us. And we will first start with the talk of Eckhard Casper and Jan Frederick about the versatility of this approach. Please, up to you.
So let me screen share, please, for a second.
Yes, just 2 seconds.
Here we are.
Back.
Current slide. All right. So thank you very much, Michel, for having me. I'm happy to contribute this talk with Jan Frederick Cornelius on the Telovelar approach and the surgical anatomy and strategy for lesions in the P fossa. And I hope to take you through this with some confidence for you afterwards to use this. We have nothing to disclose except that I've given parts of this talk at the World Federation a few times. So the Telovelar approach for P fossa lesions can be used for lesions reaching the ventricle, but also the CP angle. I want to take you through the problems, the surgical options, the detailed anatomy, and then some risks and a roadmap to success. So from a pathology perspective, P fossa lesions can either be located sort of smack in the midline, then the tumor is filling the fourth ventricle in an anatomical straight approach, or it can be a more laterally located tumor that sits in the foramen Duschke and may even protrude laterally outside. There are many possible pathologies that you will encounter in this particular location, most frequently neoplasms and especially ependymomas, subependymomas that can reach substantial size. In the pediatric population, we find a lot of choroid plexus tumors. Sometimes you can find a meningioma of the fourth ventricle, more frequently metastases, and rarely gliomas, lymphomas, or again in the pediatric population, some unusual tumors such as medulloblastomas, PNETs, or teratomas. But there are some non-neoplastic lesions I've used this for example, parasites, neurocysticercosis is one of them, and it comes in handy. So the surgical problem is really described easily. How do you get from this midline exposure in a cadaveric expression to inside the ventricle to tumors filling the fourth ventricle? So there are a number of surgical options, and access does not appear easy. If you look at a cadaveric lab without the vessels, it's not so intimidating, but putting in all the vasculature, you may get somewhat worried. And early on, people have thought about what's the best way to get into the fourth ventricle. And it again started with Dandy, who has really pioneered a lot of surgical approaches. And there were two classic approaches used for lesions, either the transvermian approach, getting smack through the midline, which gives you a medial to lateral trajectory for lesions, or you can try to approach it from a far lateral transcondylar approach for lesions that are lodged into the foramen Luschke exclusively and may protrude into the CP angle. Now, both of these have problems. The midline transvermium approach has significant postoperative morbidity, and early on this was described. If you split the midline, there are usually 3 domains that are affected, especially speech, which is called cerebellar mutism or aphonia, dysarthria, and ataxic scandic speech. There may be motor deficits postoperatively, especially with truncal hypotonia, dysmetria, and ataxic gait, which can be aggravated by retraction. And there are also behavioral problems, including memory and cognition, especially if you disconnect the dentate nucleus. Now, the far lateral approach also carries some significant postoperative morbidity, not just from an approach perspective, which is a little hard to dissect out the neck musculature, but you will encounter superficial and deep neuronal structures that are on your way, and especially variations of the vertebral artery can be in your way, and the viewing angle and window is actually quite small. So this may not work out well for neoplastic lesions. So the solutions for many of these problems is really to go through the cerebellomedullary fissure, and this approach was championed in the work group around Roton, especially Matsushima. But of course, Yajikil has written excellent papers on this, and then Kellogg and Piat in the 90s, and this was revived in the last 2 decades, and we've contributed a paper to this as well. So this is the original paper, Microsurgical and Magnetic Resonance Imaging Anatomy of the CM fissure. And the great advantage of this approach really is that it avoids splitting of the vermis. So it gives you an exquisite access to the fourth ventricle via natural planes or developmental clefts. And you can get into the fourth ventricle itself or into the lateral recess. So how do we do this? Well, first, these are the 3 key areas that you can reach. The aqueduct and the midline of the ventricle is very easily exposed. You can go into the lateral wall if you extend your opening, and you can go into the lateral recess from medial to lateral. Now, the simple scheme to identify your access corridors is you first define the CM fissure boundaries, and this is most easily done around the tonsil. So there's a uvular tonsillar space more cranially, and then laterally a medullotonsillar space. It's all about mobilizing the tonsil in the roof of the fourth ventricle. Now, if you look in a lateral view, sagittal plane, you see that the roof of the fourth ventricle is formed by the inferior medullary velum, and that is connected, laterally to the tela choroidea, which forms from the obex laterally the roof of the fourth ventricle. And if you go more to the side, towards the lateral recess and the limbus, you can reach out to the foramen Luschke. The one thing you need to be aware of, and you should study, is branches of the pica and the veins of the cerebellomedullary fissure. Now, for surgery, there are various ways how you can position the patient, and I always recommend you go with things you're most familiar with. So I'm a right-handed surgeon. I usually stand on the left side of the prone patient. The patient is head up, anesthesia sits here, and the key motion is that I do a midline approach. The same can be done upside down. Some of my colleagues operate with the head towards them, and there's a Concord position that can be used, or for more unilateral exposures, you can use Fukushima's. The key is flexion in the cervical spine to improve your viewing angle. So this is how this looks. Positioning should be done in flexion, that you tuck in the chin. And I'm not too shy to also use image guidance for these cases just to get the trajectory right. It is surprising how the viewing angle will change just with a little bit of head tilt. And don't be shy in saying I can find the tumor in the fourth ventricle without image guidance, but here you can actually get a better approach about how far superiorly you want to expose, where's your torcular, and where are the vessels involved. Again, key surgical steps, either with the head facing towards you and down. I operate the other way. Head is up, just like a Chiari exposure. It's essentially the same surgical step, especially for fourth ventricle tumors in the midline. If the tumor is a little bit more located laterally, I like Fukushima's 3/4 prone lateral position, because I will change my dural opening and expose more of one side. As I said, for surgical anatomy, the difference between the neutral position that allows you to look top down and the chin tuck is that in the chin tuck position or military position, you get a much improved viewing angle that allows you to look all the way up to the aqueduct. So military position with flexion and chin tuck really opens your viewing angle. This is another step that I consider key for intraoperative monitoring. I monitor all cranial nerves. I do direct nerve stimulation. I use sensory evoked potentials in monitoring of MEPs. That gives you surgical sensitivity that you're not pulling too hard. Now, again, when you open, take your time to make a good dural window. What I really mean this, in the cadaveric exposures, we always see these very large dural windows, which is not what we want to do in the operating room because your cerebellum may be sagging and it's much harder to close at the end. A smaller dural window that I usually do in a Y-shaped durotomy will suffice, but you want to have exquisite exposure of the tonsils. Now, when you have opened the P fossa, take a moment to really identify your vessels. This may be overwhelming at the beginning, and you will really want to break this down into simple steps. So there are 4 simple steps we have identified and wrote a little paper on this a couple of years ago. You first want to identify, as I said, the cerebellomedullary fissure, which is from the obex, the 4th ventricle outlet. And you basically want to elevate the tonsils, which is your step 2. You can do this with manual spatulus first, and then later I use a Greenberg retractor to actually hold them up stationary. Then you identify your obex and you go laterally, identify the talar. And as you split the talar, you go up towards the telovelar junction if you need more exposure. This is how this looks in the cadaveric lab, again, without vessels. So you first find your obex in the midline. The talar is right above it. Step 2 is you find the talar and identify uvula, and you want to have a 45-degree angle from the obex up and out. Then you cut your talar after you have carefully bipolared the vessels in it. There's nothing you can compromise from it. And the final step is if you need to go around the lateral recess, you can extend this laterally and out. With the vessels, it looks a little bit more intense, but it's the same. You first find the obex on the foramen of the midline. You put in a retractor. You then lift up your tonsils laterally. You've again identified the tonsils and identified the talar here. You see some vessels of the cerebellomedullary fissure that you can confidently take. Then I think you should take a quick moment and zoom in and really identify which is the area you want to gain access to. And I said start midline 45 degrees up and out. And take a moment to orient yourself. Sometimes you find variations of the pica. You may have to transpose the pica a little bit laterally, but the pica usually runs over the tonsil, supplies the inferior part of the cerebellar hemisphere. So that should be easily located laterally with the retractor. And then you could look into the 4th ventricle. Now, this is a nice paper that I recommend for all learners to read. Tomasello published this in World Neurosurgery 5 years ago. It shows you a schematic diagram of exactly what I had shown you with this idea of 45 degrees and up and out. And sorry, there's somebody stepping outside. This is a small video clip that I have included in their paper, which all of you can briefly go through. You see the tumor in the 4th ventricle, you see the obex, they elevate the right-sided tonsil, and then they buzz the lesion before they have complete access. Now, in their study, this particular paper, they looked at a very number of pathologies. And out of 45 papers, they really had a low surgical morbidity. They had no strokes. One patient, unfortunately, died of delayed bleeding. But they only had 3 patients with transient cranial nerve deficits, no cerebellar mutism, and 2 patients, based on the lesion, required a shunt afterwards. So compared to the midline approach, low morbidity, no cerebellar mutism in most cases, although that has been described as well. This is again a picture of my friend Thomas Andreas from Cambridge. He operates upside down, so the patient is with the face towards you. You are standing at the head of the patient, caudal is up, cranial is down. Here are the cerebellar hemispheres. Here's the tonsil. And the key step really is dissecting out your arachnoid, that you have a good overview of the tonsils before you elevate them. We use this in our paper just to show it's a very versatile approach. Here's a meningioma of the 4th ventricle riding relatively high up with a solid and cystic component. We're able to get a perfect access corridor and chisel this out with a gross total resection with no associated morbidity. This is a child we operated on with a solitary fibrous tumor. Again, the tumor relatively large. It would be tempting to go just through the cerebellar hemisphere, but your morbidity can be significantly reduced using this approach. We were able to achieve a good gross total resection. Finally, the most frequent case you probably will see are ependymomas. They are cystic and solid components. They're not always sitting smack in the midline, but this was one where you can see in panel D that the contralateral pica was draped over it. With our approach, we were able to really get a nice viewing angle. We were able to chisel out the pica that is now hanging in the breeze here, unaffected from the surgery. The patient did exquisitely well, could be discharged 3 days post-surgery. Now, you do have to make a decision during your surgery about the extent of your opening, but that can be quite variable. So for large fourth ventricle tumor sitting in the midline, you may open up both cerebellomedullary fissures, as I said, and you may start with the midline and then you work your way 45 degrees up and out and then down into the lateral recess. If you have a tumor lodged towards one side, there really is no reason to open the opposite side. You can do a lateral wall type exposure. And if you only have a tiny tumor sitting right in the foramen luschke, you may get away with a simple lateral recess type of opening. So this paper by Jean and colleagues, neurosurgery, shows the unilateral exposure nicely. Again, in our posterior view with the patient up, you can see they start again identifying the obex, the talar choroidea. Here, the pica is crossing your way before you can gain access. So you need to either transpose it to the midline, or I prefer to transpose it laterally, and you can gain access to the roof of the fourth ventricle, the choroid plexus, and the rhomboid lip. These were 2 lesions they presented in this paper. This was a meningioma, and this was a ependymoma with a solid and cystic component, both achievable across total resection. Now, 2 recent cases I want to show to you as a pearl. This was a young patient, 35 years old, that came to me with intractable nausea and vomiting, and outside hospital MRI had shown this ring-enhancing lesion in the fourth ventricle. I really couldn't tell what this was pre-surgery based on imaging. I always get T2 thin cuts, Fiesta or CIS sequences, because I think these are the best surgical sequences to tell you your CSF spaces. We couldn't tell, was this an intraventricular tumor? Could this be something else? We then obtained CTAs, which I do in all cases, to just study vascularity of the lesion as well as where the pica runs. So hypovascular lesion. I got a DTI, which I wanted to use to make sure that the pyramidal tract is displaced and not involved in the lesion, which is nicely shown here. So there's a good posterior access corridor to the lesion without compromising any of the fibers. But on the Fiesta sequence, we saw one of the cranial nerves emanating just laterally of the brainstem, likely 9 or 10, we didn't know, and decided to have a posterior access for this. This is what we did. So post-operatively, Telovelar approach towards one side. We were able to achieve a good resection, but it was a subtotal resection because as we were trying to peel out the very end of the tumor laterally, we got intense intraoperative signal changes in the 10th nerve. And I always get intraoperative fresh frozen pathology, which was here confirmed as a ganglioglioma, likely benign tumor. So I said there's no purpose in pursuing a gross total resection. If I damage the patient, I could back out after a reasonable decompression and follow up with the patient and add on stereotactic radiosurgery should the tumor recur. And I think that was a wise decision. The patient was without neurological deficit post-operatively. Finally, an interesting case that I did also using the Telovelar approach. I didn't think that would come up, but I had this P. fossa epidermoid that was really lodged in the foramen luschke and had an extraaxial component and an intraventricular component. So I combined the Telovelar approach with a suboccipital retrosig, and we were able to do a gross total resection for this lesion. As you can see, the lesion was nicely resected with no residual on the DWI and no neurological deficit to this patient. So I hope I was able to give you an overview that intraventricular surgery is actually fun and really exciting. I think inside the box, you do need to know your anatomy, but you can be very safe with your approach, although it is complicated. Sometimes you think outside the box and combine it with the second approach or shift it towards one side versus the midline. Use common sense and use the approaches that you are familiar with. Just think about this being slightly different from a Chiari, but the Chiari operation helps you a lot to study this anatomy. So you will see it's rewarding. And I want to then invite Frederick to later on add some of his cases to the discussion to discuss the anatomical details and pearls of his case. So thank you very much for this.
Thank you so much, Eckhart. It was a very interesting talk. You nicely demonstrate how to this access without disturbing any structure. You can reach the foramen of Luschka, you can reach the aqueduct of Sylvius. It's a very interesting approach. Very minimally invasive, I would say.
Yeah.
Then Jan, would you like to say something about the anatomy and then your case after?
Yes, I will share my screen if you agree. Okay.
Please,
can you see it or?
Not yet, but now it's in all, but not in full mode. Not yet.
All right.
More screen. Perfect.
Okay, so maybe let me add just some local notes. So Eckhart nicely described all the strategy behind. So I just want to share some experiences that we have done here in Düsseldorf. So as opposed to Eckhart, we like the modified park bench position. So we need a Mayfield 3 pinhead holder, and so we are installing the patient with a head flexed and turned down to the floor, and you need to retract the shoulder downwards and anteriorly. So of course you have to need a good fixation to the table, and you should take care of the axillary artery and brachial plexus. And so this is here on the left side what it looks like. So the modified park bench position, and here with the head looking downside to the floor, and the shoulder slightly retracted downwards. So the burr holes, we put the burr holes here below the sinus, and then we do a craniectomy, which is about 1/4 or 1/2 of the cerebellar hemisphere, and usually you open, of course, the foramen magnum, and sometimes to increase the caudorostral view, you can add laminectomy of C1. So this intraoperative photo here. Sometimes if you encounter an occipital sinus, you have to do your Y-shaped incision a bit paramedian to avoid it, and you may clip it here with some Duraclips. So this gives you the view, and then, as nicely described by Eckhart, you start your exposure with a elevation and slight lateral retraction of the tonsils, and you should look out for the pica, and then you elevate the uvula to reveal the inferior medullary velum, and so the division of the tela. So this gives you the access to the aqueduct and the lateral recess, and the division of the velum, then it increases your lateral view. And as Eckhart mentioned, you have to be very careful here for the veins of the CMF. So there's an intraoperative view. And then once you have divided the velum, you can work either in the ventricle or also can go to lesion within the floor of the fourth ventricle. Here, for example, is the illustration of a pons cavernoma. And this is a final view up to the aqueduct. So you really have a nice view up to the roof of the fourth ventricle, up to the aqueduct, actually. So closure, we always want to have very tight dura closure, and sometimes if there are small holes, we would put a muscle plug, or usually also we put some Tachocil on the suture, and then the closure is usually done with a palacus and then a very tight closure of the neck muscles and the fascia and a nice subcutaneous plane and skin closure, because this also problem of this type of approach is that you may have a pseudomeningocele or a CSF leak. So you really have to get a very good closure. Some helpful tools that were already mentioned, IO intraoperative monitoring, we used to use it. Then in some cases also fluorescence guidance, navigation, ultrasound, or the endoscope. So here is, I think we will get some very nice pictures from Henry later, but this was just to illustrate. Here's an epidermid. And so this is a view at the end of the microsurgical procedure. So we only used a dynamic retraction, no static retraction. And now we are inspecting the fourth ventricle with an endoscope. And there were some pieces here of the epidermid that were overlooked when just looking in straight with a microscope. So I think this is very helpful if you want to avoid too massive lateral retraction during all the time of resection. And this is a look, you even have the possibility to have a look downward along the spinal cord. So the postoperative considerations, I think it's very important to have a good postoperative blood pressure control, because you're operating around the medulla. And then if there were dissection near the floor of the fourth ventricle, you might encounter dysphagia or even ventilatory dysfunction. And which is also very common in these patients is that they need a lot of antiemetic drugs for at least 1 or 2 days. And the risks are the major risks of this type of approach are the pseudomeningoceles, the CSF leaks, and aseptic meningitis. So what are the conclusions for now? So I think it's important to have a very strict midline approach through the muscles. So you avoid a lot of blood loss from the soft tissue dissection, and it gives you a good orientation. And then it's you have to perform a well-sized craniotomy. Be aware of the occipital sinus and the risks of an air embolism. Then a careful dissection of the arachnoid planes and the fissures, like in Sylvian fissure preparation. Beware of the pica. Then we use, or we prefer a dynamic retraction of the tonsils over a static retractions over long periods of times, and then a very nice watertight closure of the approach. So, well, this were some local things I wanted also to share with you, and then I think we have some cases, clinical cases, that we may discuss at the end of the webinar.
Thank you so much, Jan, for sharing your tips and tricks. There are many tips and tricks in your talk. One that I particularly appreciate is the need for a watertight closure of the fascia. Most of the time it is not enough pointed out, and it is truly important in order to avoid CSF leakage, besides the other means, of course. But the watertight closure of the fascia is one of the most important things that we have to make at the end of the surgery. Can you stop to share your screen, maybe, Jan? And we will move to the talk of Henri Schröder. Henri, it's a pleasure to have you again with us. I have not seen in your title the word endoscope or endoscopy, but I'm sure that you will speak about. Otherwise, it will be a surprise. So up to you, Henri.
Thank you, Mark, again for the invitation to be with you. It's an unusual topic for skull base. I agree, but I think it's an interesting topic. Can you see my screen now?
Yes, but not in the full screen mode.
No.
Perfect.
So I would like to present my experience with ependymomas in the fourth ventricle. Ependymomas, you know, the classical classification was the grading of 1, 2, 3. There were subependymomas, myxopapillary ependymomas, and grade 2 ependymomas, and anaplastic ependymomas grade 3. But everybody who has patients recognize that this is not very homogeneous classification. For example, ependymomas grade 2, depending on the age of the patients. And that's why there were some studies undertaken to make a better classification of these tumors according to DNA characteristics. And this is a paper from Heidelberg and Toronto. And they looked at the DNA methylation of ependymomas, and they identified 9 molecular subgroups. And they found that the risk stratification for these tumors is superior to the histological grading. That's very interesting. You see there are spinal location, posterior fossa, supratentorial ependymomas. And then they found in each of these locations 3 different groups. Subependymoma, with a very benign course. And then in the posterior fossa, they have a grade group A and group B. And group A patients have a much worse prognosis. You see, they are mainly young patients. And you see the survival rate is less compared to the group B. And group B patients are mainly adult patients, and they have a much better prognosis. That's very interesting. And then they make another investigation of these group A and group B, and they looked at the progression-free survival and overall survival, and you see patients in group B do much better. So the adult population had a better prognosis than the pediatric population. And they also looked to some molecular markers like LAMA2 and NEL2, and they found if NEL is positive, LAMA negative, you have a very good prognosis. But if NEL is negative and LAMA is positive, the prognosis is much worse. I think it's very interesting. And we also look at our tumors now to make a differentiation. Is it a group A or a group B tumor? Because the treatment and follow up, or especially the additional treatment, should be much more aggressive in the group A tumors. So when you look at the prognosis of ependymomas, you see the 10-year overall survival in the pediatric population is worse than compared to adult population. This goes up to 90% with a good survival. And if you look at the very young in infancy, we have a very poor survival rate of only 50% at about 5 years. So there's clearly a difference in the behavior of these tumors. So it's not the same. It's like with GBMs. We have aggressive GBMs, and then we have more benign courses also in GBMs. So what is the treatment? Of course, for ependymoma, the main treatment is a maximal safe resection. It's different to medulloblastomas. If you have some tumor-remnant medulloblastomas, usually with chemotherapy and radiation, you can treat it. Of course, depending on which type of medulloblastoma is present. But in ependymomas, the main prognostic factor is a safe resection. Of course, radiation is frequently added if there is a tumor remnant, especially in children. But there is, so far as I know, no really effective chemotherapy available. Also no targeted therapy so far. So we, as a surgeon, are still an important part of the treatment. So classically, when I was a resident, I learned we make a transvermian approach. And we have already heard from Eckhart that the splitting of the vermis may cause a lot of problems. This was the case with the medulloblastoma. There was no other choice because all the vermis were infiltrated. But there's a high risk to get cerebellar mutism or you get ataxia. So this should be avoided. I can skip anatomy. You have heard already, when you want to go to the fourth ventricle, you just divide the telochoroidea, then you can divide the velum, and you have a nice approach up to the aqueduct, into the fourth ventricle, without touching the vermis. And that is very nice. And of course, here, the main landmarks is here the facial colliculus. And then we have the vagal trigon, the hypoglossal trigon. And the good thing in my series is that we had no tumor which was attached here. So all my tumors were attached laterally or in the midline, but always in the lower part. So I had never a problem with the facial nerve. If this is very adherent here, I think we have to be very careful because the fibers of the facial nerve run over the nucleus of the abducens nerve, and they're very superficial, less than a millimeter, and the risk of damage is very high. So what is very essential is a monitoring. When we go and expose this area, I make a mapping. I have my electrode and I look where's the colliculus of the facial nerve. I look where is the vagal nerve and where is the hypoglossal. That is very important for a safe resection. So monitoring of multiple cranial nerves is a standard in these procedures, and you should have it, otherwise you should not treat it. Positioning, you have already heard about it. We make also this Concorde position that we have a good view into the posterior fossa. When I was young, I looked from this side. Now I'm old and have knee problems. I sit here and look from this side upside down because it's more convenient. Only if I cannot look far up, then I come from here and look up to the fourth ventricle. But usually it's fine in this way. So we make a marking of our skin incision. We go to the spinal process of C2, and we go to the occipital protuberance, and then we make a midline incision. And then we expose the bone here. This is the arch of C1, and this is the spinal process of C2. Sorry, but the image quality is not very good. We place 2 boreholes, and then we cut one cut to this area, to the foramen magnum, and this cut, and then this cut over the sinus. And then we take a diamond or cutting drill and open this last thick piece of bone and remove this in one piece. This is the bone flap. And then we have here the midline and this the cerebellar hemispheres. Then we make a Y-shaped incision of the dura, and the suture, with sutures are tacked to the muscle. So we don't have tacking sutures affixed to a clamp to bring it out, but we want to pull it laterally. So I fix it to the muscle on the lateral side. And then the dura is opened. You see the arachnoid. Next step is to open the arachnoid. I resect. I don't suture it back like some people advise. And then you see we have to locate for the pica. Pica is divided. This is very asymmetrical in this patient. Here is the uvula of the vermis, tonsils and tonsils, and then we open the fissure between the vermis and the tonsils. And then we decide dissect here or incise the telochoroidea. You see this is already choroplexus. This was a case with a fourth ventricular meningioma, and then here you see the velum, which is also divided, and then you have a nice, here you see the velum, a nice approach to the fourth ventricle. You have to be careful. You should not go laterally and go more up into the cerebellar brain tissue, because here is a dentate nucleus, and this should not be injured because this may cause problems with coordination and balance. So here the plexus is cut, and here's already the meningioma, and this is the last piece of the velum, and you have a nice view to the fourth ventricle. And then you always can see the aqueduct without incising the vermis. You can always look up to the aqueduct in these cases. And this is after the surgery. See, there's a bit of superficial laceration of the vulnerable tissue of the cerebellum, but this has never a clinical sequelae. And after the closure, we always take some substitute to close the dura, because in my experience, I can never have a watertight suture in the posterior fossa, especially because sometimes you have to coagulate here the suboccipital sinus. So we take bovine pericardium, or like here we have the duragene suturable, which we take to close it. And then, as Michael mentioned, a good closure of the muscle and fascia is important to prevent CSF leakage, because always in the post-op MRI, you see some CSF accumulation in this area. Then we fix the bone flap with 3 mini plates, and then we have the suture. So what is important, in my opinion, is we use a forehand suction irrigation technique because you always want to see the good plane between the ependymoma and the floor of the fourth ventricle. And you know, the tumors are a little bit bloody sometimes and you don't see well, and then it's very difficult to dissect. The first case we did in a sitting position. This can be done, but the way for direction is from below to up. So it was not very helpful. That's why we have now this technique forehand suction irrigation. That means my assistant has a suction and irrigation and gives me always a clear view for dissection. And then traction counter traction is used. So we pull the tumor with one forceps and then we dissect the normal tissue away. You see here, this is a bipolar. This is the floor of the fourth ventricle. This is the ependymoma. I have the suction in my left hand, and I try to find the plane. It is very adherent, but usually you can find a plane and dissect. This is a small perforator here from the brainstem. You have dissected carefully. And here's a forehand suction irrigation technique. So I have my tumor forceps, and with the left hand, I dissect here the arachnoid plane away from the tumor. My assistant has a suction, and here is the syringe. Here again, you see this is a suction. Tumor is adherent, lateral, but not at the floor. So with a traction, counter traction technique, carefully, millimeter by millimeter, the tumor is dissected from the tissue, from the brain tissue. And I think the major rule is, and that is the most important fact which we have to keep in mind, no coagulation at the floor. Because if you coagulate, the nuclear nerves are less than a millimeter below the surface. Even with very low power, no coagulation at the floor. Always place some Surgicel with a paddy on it, but never coagulate, because this can be a disaster. And I know because I have seen what's happening if people do that. So my first case is case 0. This is a 25-year-old male, facial palsy, hemiparesis, sensory loss in the face. He came with this tumor. And this tumor was mainly in the CP angle. So in this case, we did not make a Telovelar approach, but we made a lateral approach, retrosigmoid approach, and then we resected this tumor. He was 6 years post-op free of tumor, but died unfortunately from bronchial carcinoma because he was a heavy smoker. So the Telovelar approach, first case is a 26-year-old male. He had recurrent tingling sensation in arms and legs for 6 years. He was neurologically intact. Multiple sclerosis was suspected by neurologists, and he got an MRI, and they found here a tumor, the fourth ventricle, attached to the obex. This was in sitting position, so we dissected the tumor from the fossa gross total resection. Post-op, he had a left abducens palsy, and he had a really arterial hypertension, which was difficult to treat. So this was clearly an irritation of the medulla by my dissection. But this resolved after a time, and 7 months later he came for follow-up. You see there is no tumor remnant. He was neurological intact. And then he came now 15 years later, no recurrence, still neurological intact, fully employed. So gross total resection without any adjuvant therapy. And also T2 weighted shows no tumor remnant. Another case is a 1.5-year-old male, and he had pneumonia and balance problems, and he was already able to walk when he was 1 year old, and then he was not anymore able to walk, and then they made an MRI, and this shows hydrocephalus and a huge tumor which extends to the foramen minuscule more on the right than on the left. And here you see the contrast enhancement is not homogeneous, but there seems to be one type of tumor, and inside it looks a little bit different, like an anaplastic type. At first we made an ETV to treat his hydrocephalus, and then 2 days later we made the surgery. You see this is the tumor already. This is a tonsil, so we dissect the arachnoid. Usually the telochoridia is already gone because of the tumor pressure. So it's easy to get access into the fourth ventricle. So at first we take tumor for the histological examination. Then we mobilize the tumor, and you see there is less adherence here. The only problem is the small perforating vessels are very adherent and sticky to the tumor, so we have to be very careful when dissecting it. So tumor debulking was bipolar. And then you see here also small brainstem perforating arteries are very sticky to the tumor. And of course, these vessels have to be preserved to prevent a brainstem infarction. But in general, the tumor was not sticky to the brainstem at that level. This was very good. So we dissect the small vessels away from the tumor. And then we have access now here. This is the fourth ventricle. Always when I see the fourth ventricle, I put a patty inside to protect it. And then I see this is the attachment area. It's lateral, but it's not much. So I was surprised. The tumor was just a little bit adherent at the lateral recess of the rhomboid fossa. And you see exactly, I tried to find exactly the plane between the rhomboid fossa and the tumor. I think this is the most important step, that you really dissect exactly at the border. And here, after reaching this area, now the tumor is already free. It is no longer attached. So this was the good thing in this tumor, that the rhomboid fossa had only a small area of attachment. And then ultrasonic aspiration is very nice for resection. And you see now we come to the tumor, which extends into the lateral recess. Here you see some plexus, which is dissected away. And then I use CUSA to debulk the tumor in the lateral recess. And here again, there's a good plane. There's a good dissection plane between the tumor and that area. Coral plexus is dissected. And then I was very lucky because this pole, the tumor, came out very easily from this area. And then you see here coral plexus, and you see already here glossopharyngeal nerve, probably. And then we have to dissect the tumor from the cerebellum, from the vermis. This was easy. There was not much adhesions, and we cut the arachnoid, and then we could mobilize the tumor again. Here's the vessel, take care of that one. Ultrasonic aspiration again, debulk the tumor. And you see now the tumor looks different. There was a yellow thing, very firm, much firmer. The tumor, this seems to be another type or another type of tumor. Looks different to the tumor which was surrounding. And again, in the foramen, lateral recess on the other side, this tumor is not very sticky and came out easily. Again here, arachnoid plane, coral plexus plane, dissection, by manual dissection, traction, counter traction. And then after dissecting the tumor, we can take it out in multiple pieces to avoid too much retraction to the cerebellum. And then we have a nice view to the aqueduct. You see it's not much retraction required because the tumor opens up the fourth ventricle and gives you a lot of space. And this is the rhomboid fossa. You see the tumor was just attached here on this side laterally, but all the midline is free. This is the facial colliculus. This is the stimulator after surgery. And this is one of the lateral recesses. No tumor. And this is the way it looks after surgery. You see it's a little bit superficial damage to the tonsils and the uvula, but it's nothing clinically relevant. So this is the one day after surgery, no tumor remnant. And histology turned out to be a group A ependymoma. You see key 67 is very high. And then although the child is so young, they sent him for proton beam radiation. That was very surprising because I advised against radiation because I thought the malignant part is central and all around was just benign. Sometimes our pathologist said sometimes it looks like a subependymoma. So I was not in favor of proton beam, but you get radiation. It's now 1.5 years after radiation, looks good, no recurrent. And the mother sent me this image, and he is moving and he's doing fine, and she is happy. But I'm concerned with radiation of these small childs because I'm afraid this had a sequelae later on. So another case was a 29-year-old female, headache for 1 year, and she had problems with her arms. Neurologically, she was intact. Then an MRI was done, and this was the most difficult tumor because there was a long adhesion of the tumor to the brain stem. You see severe compression of the medulla. And the same thing, this is a forehand suction irrigation technique. The tumor was very sticky, but you see because of this continuous irrigation and suction, I have always a good view. Even if it was bleeding, I see the plane between the rhomboid fossa and the tumor. Here, forehand traction, counter traction. I grasp the tumor, and then I stay in the line of the ependyma. It's very important that you exactly find the border, but because of the good visual differentiation between the white floor and the grayish tumor, usually you can dissect. And you see the pia mater of the brainstem is intact, also small vessels. And if the monitoring is not making too much noise, I continue. We had always some response in the monitoring from the hypoglossal nerve, but this was not very concerning for me, so I continued with the dissection. If it would be the facial nerve, I would be very conservative. But the hypoglossal, even there is some response, I continued with the dissection. You see here again, this is a layer, and because of the suction, I have a good view. If I would not have it, I cannot make traction counter traction because I don't see. And this after the surgery, you see the colliculus is free, but here was a long adhesions on both sides. After surgery, she had apraxia of the right hand. MRI shows gross total resection. This is 14 months after it. And then we saw her 5 years later. She was still fully employed, neurological intact. And so far, she has no recurrence, no radiation, no chemotherapy. The last case is a 32-year-old female. She's a nurse in our hospital, and she became symptomatic with untreatable arterial hypertension, tinnitus, dizziness, headaches, and then she had a pupillary difference, neurological, but she was intact without only with this difference in the pupils. And then she got an MRI, and you see here is a tumor and a little bit hydrocephalus. But the hydrocephalus was not a major problem, so we did not an ETV in this case. But we went for the surgery. You see here the tumor extension. You see also tumor extension here in the foramen Luschke on the right side. Here on this side, you see it here. And again, the tumor was very sticky to the brainstem. And we used suction irrigation technique, find the plane. Here again is the plane between the brainstem and the tumor. With a sharp pointed forceps, you can also dissect by spreading it carefully, try to find the way. And here it went very deep into the brainstem, and we had a lot of response from the hypoglossal nerve, but I had a good plane visually, and I continued with the dissection. There was not much noise in the vagal nerve, but in the hypoglossal. Then we dissect the tumor here. This is all attachment area. Then we have the monitoring with the electrode, mapping of the floor, ultrasonic aspiration. And then there's tumor in the Luschke. Here on the right side. Dissected, it was sticky. Then the cord plexus is coming, but it was still a good plane visible between the brainstem and the tumor. And this was then resected post-operatively. She had an abducens palsy, dizziness, balance problems, glossopharyngeal palsy, and hypoglossal palsy. 1 day after surgery, she showed progressing hydrocephalus. You see here the cortical relief is very flattened. So we made an ETV, and after ETV, the ventricles came down. There's a good flow void in the ventriculostomy, and she's doing fine. Now, 4 months later, she was improving, was neurological okay, starts to go to work. 5 years later, she came here with a recurrence in a Luschka. You couldn't see it in the T1, just in the T2 weighted images. And then we went back for surgery. The part in the fourth ventricle was easy to remove. Again, there was a very good plane between the brainstem and the tumor. And then in Luschke, it was a bit more difficult, it was very sticky. Traction, counter traction to dissect it from the floor of the fourth ventricle and the lateral recess, and ultrasonic aspiration is used to resect the tumor in Luschke. Go first, and the cord plexus is coming. It was very sticky. You see there's tumor on the cord plexus. But with 2 forceps, I tried to dissect it out. And you see here, this seems to be the cranial nerve. With stimulation, we had response in the glossopharyngeal nerve. And then with an endoscope, we looked, is there any remnant? And we saw just here the cord plexus, but no clear tumor remnant. And this is now 7.5 years post-op. So far, no recurrence. If another recurrence would come, I would go for radiation. If you compare some to the literatures, there's a recent publication about 22 fourth ventricle ependymomas. They use the bilateral Telovelar approach. I never used bilateral. I always go from one side because I can retract the vermis to the other side. So I don't know why they do bilateral. I always do only on one side. There was no death, no mutism. They had 4 permanent cranial nerve palsies, and they had 4 shunt-dependent hydrocephalus. And we have published our experience with the forehand suction irrigation technique in working with surgery. And in this series, we had a gross total resection of all these patients, and we had no recurrence. This is a lady which came later with a recurrence, what I showed you in the foramen Luschke. There's another case also with this tumor in gross total resection. The conclusion was that the forehand suction irrigation technique leads to gross total resection, and there is no need for radiation in adult patients. But of course, you cannot compare to pediatric patients, what I have shown you. Now we have, also I myself have 14 cases of cranial, of ependymomas in the fourth ventricle. We had 1 recurrent tumor, which had surgery before. We had 3 occlusive hydrocephalus. In 1 of them, we made pre-op the ETV, and in 2 of them after surgery. And we had gross total resection in all but 1. In 1 case, the part in the Luschke was really going around the vessels. It was very difficult, was not pushing it away, but was encasing everything. But we have no shunt-dependent hydrocephalus, so I strongly recommend ETV in these cases to avoid shunt dependence, and we had so far one recurrence. So my conclusion is that the Telovelar approach is a nice approach for fourth ventricular ependymomas. I strongly recommend for hand suction irrigation technique because it gives you such a nice view. And the main message is please no bipolar coagulation at the floor to avoid permanent neurological deficits. Thank you for your attention.
Thank you so much, Henry. Very nice, exceptional videos. You highlight a very wonderful technique. And I perfectly agree, of course, with you with the fact that you cannot apply anticoagulation. And in order to be that, it's easier when you don't have a bipolar forceps in your hand. As I've seen, you dissect as I do also with the dissecting forceps, and with 2 forceps you can very accurately dissect. It was one of the questions that I see in the question and answer box. Which instrument do you use? It is a regular forceps, very accurate forceps.
Yeah, sharp pointed.
Very interesting technique, and you that when you have to dissect very sensitive structure, you made the debulking before in order to have to under a mass which is restricted. And it was also a question, do you use the ultrasonic aspirator? You have demonstrated that yes, it's truly important to debulk the lesion as much as possible before dissecting very sensitive structures.
Yes.
Thank you. And then we move now to Tübingen, and it's a pleasure to invite with us Professor Martin Schumann, working with Marcos Tatagiba. I see that you are connected, Marcos, so it's a pleasure also to say you hello. Thank you to be with us this afternoon. It's also a pleasure. I see that the ENS officers are also connected. I have seen Professor Johan van the treasurer, and also Andreas Dimitriades, who is the president-elect of the ENS. So welcome to all of you. So then we move to Tübingen. Please, Martin, up to you.
Okay, thank you very much for the invitation to give the pediatric perspective on posterior fossa tumors. So I hope you can see my presentation now.
Yes, perfect.
Okay, good. So thank you again for inviting me as pediatric neurosurgeon to talk about the pediatric tumors, because as you well know, posterior fossa tumors in children are very frequent. It is the most abundant localization, accounting for about 60% of all pediatric brain tumors, which in general are rare, but in the pediatric centers you of course accumulate the cases. So the fourth ventricle and the posterior fossa is something pediatric surgeons spend quite a time of their life inside. So moving from the front to the back, we have the brainstem tumors, the DIPG, and the exophytic low-grade brainstem tumors like pilocytic or ganglioglioma. Then we have the large mass of tumors which reside in the fourth ventricles, which are the medulloblastomas, the ATRTs, the ependymomas, and the fourth ventricular PCAs, pilocytic astrocytoma. So there is a group of truly fourth ventricular pilocytic astrocytomas. Then we have the hemispheric pilocytic astrocytomas, which is the largest group in the pediatric posterior fossa collection. Very rarely we have WHO grade 2 tumors in children. And then we have the more rare, mostly pure cerebellopontine angle tumors in children, like vestibuloschwannomas, meningiomas, mostly in NF2 cases, the plexus papillomas, sometimes epidermoids in children. So today we are talking about those tumors residing mainly in the fourth ventricle, which are the medulloblastomas, ATRT ependymomas, and fourth ventricular PCAs. So we already heard in the excellent anatomical descriptions of the Telovelar approach, the locations in the fourth ventricle. So I'm just summarizing that. Where do we have to go in the fourth ventricle? So that's the roof, which is the vermis, and we have the lower, the middle, and the upper vermis. And then in the very top, in the very end, the velum. We have the walls of the fourth ventricle, which basically the three cerebellar peduncles, the lateral recess, which ends in the foramen Luschke as the door to the CPA. We have the upper floor. Upper floor is above the facial colliculi, so the part of the floor where you have very little or no, where you have no nuclei directly under the surface. And then we have the lower floor, as Henry told you and showed you, with the relevant and most important cranial nerve nuclei. We have the inlet, which is the aqueductal entrance, and the outlet, the foramen magendi and the obex. And these areas, all areas in the fourth ventricles, are important as origin zones for tumors and or infiltration zones. And so we want to have an approach which actually reaches all that areas. Traditionally, you know, and it has been mentioned already, the transvermin approach has been the standard approach, also in pediatric neurosurgery. And this has changed now a little bit, or mostly in many centers, to the Telovelar approach. As you all know, as neurosurgeons, location are the three most important aspects. It's like in real estate. And certainly the supracerebellar or in the upper cerebellum, you treat by infratentorial supracerebellar approach. But everything else, which is here in this graph, still separated in transvermin and telovelar, can be treated actually, in my opinion, by telovelar. So here in this sketch from a pediatric posterior fossa book, actually, they still propagate the transvermin for the upper lesions, which I think is not indicated and necessary. So I'm showing you here 4 posterior fossa tumors. These are the typical cases in pediatric neurosurgery, not the large one. This is at least the minimum size which you have until a child becomes symptomatic and is diagnosed. So that's the standard tumor. And all of those you can reach easily by a velotelar approach. So if we come back to the locations we have just been talking about, you see everything is in green. All the areas which I talked about can be reached by a velotelar approach, and similar to Henry, I'm mostly using a unilateral on that side, which is kind of the most easiest to open and which just offers and calls for the surgeons, please open here. So you use that side if you have a bilateral tumor. If you have a unilateral tumor, you go on that side where the tumor is. One is a little bit in orange here, the middle vermis, and that is because this is the area where your view, your angle is the most unfortunately, let's say like this, in that part of the roof, you have a very flat angle. You see basically alongside the vermis is and you don't have an on top view. So this is the area where we have the highest risk of residual tumor, which I know from some of my own cases and also from as working as a panel neurosurgeon. You see quite a lot of recurrence also in other centers happening up there. So the best thing to avoid residual tumor here is something we have already seen. I'm sorry, we are getting a helicopter here, so I'm just waiting for a second. Because the helicopter comes over my room. Okay, so the additional use of an endoscope, we have seen a KEVO in one of the previous presentations, or any 30 degree, 45 degree endoscopes helps you to actually have a good view to that angle and avoid to have residual tumor up there. And what can be reached by the Telovelar approach with the subtonsillar approach in our terminology is that what we have already seen as the approach to the lateral recess. And when you open the lateral recess alongside the pica and all those vessels, you have an access to the whole lower cerebellopontine angle. Lower is everything below 7 and 8. So you can see 7 and 8 from down there. You can see everything, the cranial nerves down to the entry of the vertebral artery. So by this little extension opening fully the lateral recess, you also gain a very good access. And I'll show you examples that we need this in pediatric neurosurgery into the cerebellopontine angles. Now let's talk about dura opening a bit. We had both of the previous speakers have been talking about dura opening, and the standard certainly is the Y shape, and you find it in all textbooks. It is Y shape and it is Y shape here, and only in the posterior fossa tumor book in children somebody mentioned something like a U fashion. And I'll talk a little bit about the U fashion to give our opinion on how to avoid problems with the Y shape. One of the reasons why Y shape is a little bit problematic in children is the occipital sinus, which divides in these two outflows, which sometimes one is dominant. And most children below the age of 5 will have occipital sinus, and the older the children come, it gets better, but you can be surprised to have that also in older children. And it can be rather broad, much broader than in adults. And if you do a Y-shaped incision, you're cutting immediately inside the occipital sinus. And as Henry mentioned and others, you have to do some coagulation. And if you coagulate, it shrinks. So better do stitches or try to avoid cutting in that area. And the other problem with the Y-shape is you have to do the retraction sutures to expose here. And when you lift the dura out with the retraction sutures, they start to dry. And if you have a drying dura, it is going to shrink. And together with a shrinking dry dura and having 3 pieces of dura here, This creates the problem with dura closure. You need a high rate of duroplasty. In the literature, up to 50%. Henry said he always uses it. So this is a problem that is created by the Y-shaped incision, and pseudomeningocele and CSF fistula are well-known problems. We have been using ever since a different technique, which is the U-shaped technique. If you have to resect, in some cases, C1, you extend it down here. Otherwise, you take the upper incision line, and it has many advantages. You have less interference with the large occipital sinuses. You don't interfere in the middle, you interfere laterally, and you have a good lateral exposure. That means you do not need any retracting sutures at all. Everything stays inside, is moist and clean, and doesn't shrink. You have a better closure, you have a low rate of duroplasty and a low rate of CSF fistula. So I'm showing you here an example. We have a wide and nice craniotomy exposure. Here's C1, and then we cut down from here, and we cut down from the other side, and we have a nice Y-shaped exposure, which totally exposes everything you need to see. You can dissect now both sides inside the ventricle, and afterwards you can do a very nice and easy dura closure. And this is a different case, the same principle. Doesn't matter whether you stand on top of the head or the side of the head. And another problem we have in children is the sinus management in very small children, and how to control the bleeding, because a child you can lose as much blood by opening the posterior fossa that you get in real trouble. So here we have a 4-month-old baby with a posterior fossa lesion, and we have again do the U-shape opening, and you see suddenly already that far up the bleeding starts, not far below because most of this posterior fossa dura basically was a venous sinus. So you have to do stepwise little cut, you put in clips, and this way you work all your way around, cut, clip, clip, cut, clip, clip, so you don't lose too much blood. And for a 4-month-old, that is already too much. And then you need to run a suture, because if you try to close that later on, one of those clips will come off, or it comes off during surgery, and you will have a catastrophic bleed in the posterior fossa. So we close this with an elastic suture. Here I'm using Gore-Tex suture, but you can use any monofil suture. And nevertheless, you can easily close the posterior fossa. So if you have to do these kind of sutures, we still can do a primary closure without duroplasty. We investigated and published this in 50 consecutive unselected pediatric cases in the posterior fossa of different types and different locations. And we had 44 primary and 6 secondary openings. One was after an external Y-plasty, all others were secondary after own U-shape opening. No lateral retraction sutures in 0 case. We had this one case I showed you, which was a little bit critical with the control of the sinus. We had a complete primary dura closure in 49 of 50 cases. The only case where we needed a duroplasty was there where there was an artificial duroplasty before, after Y-shape opening. No CSF leaks, no infections, no pseudomeningoceles on follow-up MRI on the next day and at 3 months. No post-op hemorrhage, and one revision for superficial wound dehiscence. So with this kind of approach, you really get rid of most of these dura opening problems and associated problems with CSF fistula, and you don't need duroplasty. This is just literature in a large pediatric series. 45 had a dural graft, and they had 37 pseudomeningoceles, 41 dural grafts. So a total rate of pseudomeningocele and leaks in 33% of the cases. So I think there is some truth about the problem that the Y-shape incision per se induces in that dura opening. Now we show you a short video of a typical velotalar approach in a child. most of the time our tumors are very bulky, as you see, and so part of the velotelar approach is already done by the tumor because the telar and the velum is stretched out and is extended. So it's much easier actually to do a telovelar approach in a large posterior fossa than in the more usual smaller tumors you see in the adult population. So we are opening the dura. I standing on top of the head for the opening. And if I have to go way up in the fourth ventricle, I'm switching position to a lateral position as we heard before, because then you can very easily look up in the fourth ventricle and dissect in the roof area and around the aqueductal inlet. So we are doing the dissection alongside the cerebellomedullary fissure, and here we are choosing the left side or the right side of the patient. You see the tumor has already done some of the dissection. It's already protruding outside. You get the entry to the fourth ventricle. You can put in a pedi in there. Most of the surgical techniques Henry has already nicely demonstrated. We dissect the vessels, the pica down here. This is part, it's not the large pica, so it's coming a little bit more lateral. It's a smaller vessel. So you orient yourself. There comes the choroid plexus. We easily saw the choroid plexus. So before I start debulking, I first get my orientation and totally complete the dissection on both sides. Identify here is clearly the pica, which you have to identify first. So you need to know your landmarks before you debulk. And in medulloblastomas, it can be very bloody when you start the debulking. So first of all, you need to know your landmarks. And then you continue the dissection of the cerebellomedullary fissure all the way down, so that later on, after you have debulked the tumor, you have an easy access to the whole fourth ventricle without the need. Here comes another tumor feeding vessel probably, which crosses over alongside the vermis. So you need to know these vessels, and you only coagulate the feeders to the tumor because it might well go into the vermis itself. So this is at the end of the resection. You see I'm standing now sideways. I've changed my position, and it's very easy to look all the way up to the aqueduct, and then you start the dural closure as described before. This is a typical medulloblastoma case, which is the usual size, and you get a nice exposure and the opportunity to remove it all. This is classical ependymoma in a child, posterior fossa type A. You heard from Henry that you have the type A, type B. Unfortunately, pediatric neurosurgeons are mostly confronted with the PFA type, which have not a very good prognosis, and an 18-month-old boy, its only chance for survival is gross total resection, plus radiation therapy, which is mandatory in these children as soon as they are older than 1.5 years. And you see here, again, different tumor types, partially cystic, partially contrast uptaking. I didn't take those because they were not good in quality, extending down to C2. And here we had to remove C1, and you see an extension into both CPAs, lower CPAs, which you can nicely totally expose by a subtonsillar approach, even get around the corner. And this was the postoperative result. And he is now 2.5 years after surgery and radiation, and is free of tumor and has a fair chance to belong to those children who survive. A last example is phagocytic astrocytoma of the medium medullary superior, or the dorsal midbrain. Actually, it came from the dorsal midbrain in a 17-year-old girl, which had hydrocephalus clinics mostly, and it's a typical PCA. And the question was how to approach it, and the best and most unproblematic approach is to do a nice velotalar approach. In these tumors, you really have to dissect it step by step, as you have seen it before, because there's no tumor that helps you with the dissection. So you do the stepwise dissection on one side. In this, I choose the contralateral side, so I can the tumor comes from the left dorsal midbrain, so I use the right-sided approach, so I have a nice trajectory up alongside the aqueduct. And this is the immediate postoperative scan. This was a few weeks ago, this case. And we think we have reached a gross total resection in this girl without any sequelae, then a little of parino or double vision for a few days until discharge. A last word to cerebellar mutism syndrome or posterior fossa syndrome, because this is most relevant in pediatric neurosurgery. And as you heard, the transvermian approach has been accused of being one of the main reasons for prevalence of 10 to 15, sometimes 25% of cases, depending on the series. We have cerebellar mutism syndrome, which severely affects these children and can really change their quality of life forever, because some children really do not recover well. And there are several theories. There are even a posterior fossa society in pediatric neurosurgery, which is busy with that problem because it's not well understood. We think that injury to the vermis, and especially the subvermian deep cerebellar nuclei, like the fastigial nucleus and the globosi here, very clearly an interference with the dentate nucleus and the dentatorubral tracts in the upper cerebellar peduncle are most likely associated with mutism, and you get these olivary hypertrophy on the contralateral side as a result of this disconnection. So there was a big hope that using the TVA, the Telovelar approach, would reduce the incidence of posterior fossa syndrome. And unfortunately, this has so far could not be shown. There's a lot of publications in the last 5 and 10 years of retrospective nature when the people actually looked in their series, and they could not clearly show. There were trends, but it has never been absolutely statistically significant that the TVA actually reduces it. And last April, we had the first results from the European Prospective Nordic study, which is a multi-center pediatric study to which we have contributed here in Tübingen. And actually, with more than 500 children, it failed to show a lower CMS rate in TVA. It was even slightly higher, not statistically significant. So it is not in press. So this was quite surprising to all of us. And we think, and my hypothesis behind it, why that doesn't work, is that the approach alone is not the only factor. In these children with invasive medulloblastomas, more than ependymomas, we have a higher CMS rate in medulloblastoma. It's also the tumor invasion to the nuclei. You have to resect if you want to take out the tumor immediately in the border zone, in the infiltration zone, and that is next to, for example, the dentate nucleus or the cerebellar nuclei. And we certainly also have a problem from retraction, and especially in TVA. And Henry had made the point, you should have a dynamic retraction, you should relax as often as possible. And if you want to reach up very high, you need to have a good dissection. And if you don't have a full exposure of the fissure, too much retraction might actually damage part of those nuclei you want to prevent or you want to save. So in our series of the last 12 years of forced pediatric ventricular tumors, it was 108 tumors, medulloblastomas, pilocytics, ependymomas, and ATRTs. We have only done TVA. We have not used a single transvermin approach because I don't think that is necessary to reach the goals of surgery. It is our standard approach combined with the U-shaped dura opening I demonstrated to you, and we only do C1 resection if the tumor extends below you do not need a C1 resection to look upwards, as this is still in some textbooks. So I thank you very much, and I hope I could show you the pediatric perspective on this very versatile and useful approach to the forced ventricle. Thank you very much.
Thank you so much, Martin, for your talk. Very interesting also to share your tips and tricks. I see on your slide that it's evident that you have access to all the structures, all parts of the fourth ventricle. Very interesting. And you highlight also the hidden part. It's why the combination with an endoscope can be interesting in this area of the vermis. I received one question, but you are surely the best to answer that, since you work in Tübingen, where the sitting position is daily used. I read a question of one people of the audience asking, is there any experience of the sitting position for the Telovelar approach? I can have some arguments against, but I think maybe you are the best to answer to this question.
Well, actually, although we are a clinic which is extremely used to the semi-sitting position, which I also prefer for CPA tumor and dissection of cranial caudal nerves or cranial nerves in the CPA, in children, we actually use the, in the forced ventricle, we use prone position in the majority of all cases. So it is, I think it's in children, the positioning problems which you have in adults is not so relevant. It's very easy to get a good exposure. They have very flexible heads. So I don't see the need for a semi-sitting position. The technique of an assistant having the suction and irrigating, as Henry has shown, so that you can do your two-handed dissection, which is one of the main advantages of the semi-sitting position. You can have part of it. Of course, you still need some suction, which you wouldn't need in the semi-sitting position. But I think inside the forced ventricle, I don't see the need of sitting. And the disadvantage of the sitting position, if you're on the forced ventricle, is the massive air inside the head and the air in the ventricles, and you really avoid that. So it's not routine here for forced ventricular surgery. The
over drainage of CSF. And Henri has a comment?
Yes, and I think you need much more retraction to open up the forced ventricle. If you have the prone position, you can have the retraction with your suction, dynamic retraction, and in semi-sitting is not possible.
I agree. Mm-hmm.
It's also interesting, and I jumped to this area of the discussion. Interesting to see the result of the Nordic study. And if just one question about the dual incision. When you perform a U-shaped dual incision, just Y-shaped incision is just with a small contra incision. But on the other hand, it gives you a more caudorostral view, more oblique view, especially for the cranial part of the fourth ventricle. So is there any comparison in these Nordic studies about the lesions induced by the retraction? Because if you perform a Telovelar approach with retractors, and I must say, I'm able to make the access until the aqueduct of Sylvius without any retractor. It's more dynamic retraction. The instruments are used as retractor in place of a true retractor blade. Is there any data in this study about the ischemic injury in relation with the retractors?
We will see. I mean, these were just the first results, and now this will be published, and I think many papers will come out of this analysis. So we really have to see if we can identify surgical factors. And this will depend on the quality of the operating notes, if you have a multi-center study. But I think the main problem in the pediatric cases is the infiltration of the tumors coming out of the vermis, the medulloblastomas, and the pilocytic astrocytomas, which have the highest rate. And it might be a problem of surgical radicality. So there is a shift in philosophy also in medulloblastomas, because the majority of them, in contrary to ependymomas, are quite chemo and radiation sensitive. So we do not need the radicality in medulloblastomas anymore that we absolutely need in ependymomas. I mean, the very little piece of ependymoma which is there in a child will come back, and it is not sensitive to radiation or chemotherapy. In medulloblastomas, I think we will see a shift on radicality, so you do not really need to attack the infiltration zone. If you are R1 or even a very small infiltration zone where you know there is a little bit of residual tumor, I think you can leave that. And I think that is more the clue to decrease the amount of posterior fossa syndrome.
Just one small question. Also, you take your time to discuss the U-shaped incision, and you show very interesting results. But I'm pretty sure that in your hands, with such result, if you do an Y-shaped, Y-shaped incision, your result will be so good also. If you want a comparison of your both kind of incisions.
Well, can I chime in?
Yeah.
So I think there's a difference in pediatric dura to adult dura, the water content, the stretchability. And therefore, I think for the pediatric patients that have a higher incidence of the midline sinus, as well as just more vascularity to this area, the U-shaped incision is wonderful because you can achieve a primary closure. I've not once tried to do a primary closure in an adult. I always do duroplasty. I always use the dural autograft, so pericranium. We've published our series with 100 dural grafts and 1% meningeal from a dural dehiscence. But I think there's just a difference in technique because you get a different material. In the adults, you may get less water content, hence less shrinkage, which is one interesting aspect. You can use the Y shape because you have a wider field in principle to start with. The whole thing is bigger. And I think the viewing angle is not compromised. I've never tried the U shape, but I'm happy to try this. It may be harder to sew in a dural graft when you do a U-shaped opening in an adult. So I think each of us has developed a slightly, modified personal technique on this. And what I take away from today is these little steps of, each of us has one good move, the forehand suction irrigation technique, perfect viewing angles and perfect visibility of the two different tissues. The normal brainstem versus the tumor is one of them. I never use patties in the fourth ventricle because I think they're too rough. The surface is rubbing the fourth ventricle. I put a rubber down on the floor of the fourth ventricle. I never move that piece of plastic, and therefore we have no bruising in that area, and that has shown to just work well. But I really like these single aspects of each of you telling us, let's try something, to improve our technical skill set to tackle these challenging tumors.
Becky, you have the wrong patties.
That is very true. I'm not going into this in Canada. It's a major problem.
Yeah, but I think I can also encourage you to use the U-shape in adults. So I'm also operating on adult cases, and I'm not making the difference. So I do a U-shape, the same thing in adult, and I have no problems with closing. And you don't have to do that retraction sutures, which really bring the dura too much helicopters today.
Yeah. I have also used U-shape, but with the Y-shape, you can go more deeper to the spinal canals, and you cannot use a U-shape. If you go if you go further down at the level of C1 or sometimes to C2, you cannot make a U-shape. You have to make a Y-shape because you are in a spinal dura.
Yeah, well, I do a U-shape also when after resection of C1, I just make the U small enough. Below C1, if you have to go down, if you have to in an ependymoma and you have to take down C2, C3, C4, if you have to go so far down, of course you do a straight incision in the midline. But for a C1 resection, I would do a U-shape as well. Just a smaller U. I mean, you just have a small
U, almost a Y. Why U? Why you a Y-shaped U? You mean? Okay.
But that's personal pearls. So that's a good thing about here. We can exchange experience, and I think that is one of the main important things of these webinars.
I have one question. Martin, you mentioned that we have to be radical with ependymomas because they are no radiosensitive. But you said you send all your pediatric patients for radiation. How does this fit together? Because
the best survival rates, and that is anonymously recognized in the pediatric oncology world, is after gross total resection without visible tumor remnants intraoperatively and also on the scans, plus irradiation. And this is the best chance for survival for these children. So I totally agree with your oncologist that after your beautiful surgery, they did an additional radiation. But if you have visible tumor remnants on this postoperative scan, and then you start with radiation therapy on that, you most likely will have a recurrence in the due course. And we even have in the new Ependymoma protocol, in the European protocol, it is mandatory that before you do radiation therapy, that as part of the study, you get a second surgical opinion whether this residual tumor should not be attempted to be resected. So, because the data are very clear.
So the tumor must be radiosensitive, at least a little bit.
At least a little bit, if you have no residuals, so if you have a very, very low tumor burden, which you cannot see macroscopically, then radiation is effective. But if you have too large, if you see something, it's not going to work.
Do you also use proton beam, or what are you using?
Yeah, whenever possible in children below the age of 6 or 8 years, we would try to use proton beam, and the younger the children, the more you would like to have proton beam because it's more focused and you have less damage to the surrounding brainstem and cerebellum. And the cerebellar radiation-induced injury is that what gives you the cognitive problems in these children. And if you irradiate a 2 or 3 year-old child, you will have sequelae. And we hope that in 10, 15 years, we will be able to show that you have significantly better cognitive outcome after proton beam, but this needs to be shown.
Yeah. We already started a nice discussion, but it is not yet finished. And we will prolong this discussion with the cases of Jan Frederick Cornelius.
I'm looking forward to that.
Jan, please show your cases and we'll...
Thank you. We have heard a lot and very interesting talks about uro-oncology tumor cases. So I just flipped a bit around to show you some. So this is just to mention that we are not working alone, of course, but in a big team. And so I wanted to share this case of a 64-year-old female who had acute headache and dizziness. And so she had this MRI, which showed a carcinoma of the left cerebellar peduncle. And after counseling about the pros and cons of surgery, she opted for a surgical resection. And so this is the post-operative. So we did it in the park bench position with a intraoperative monitoring and with a Telovelar approach. And this is a post-operative MRI at 3 months time. And you can see here there was a little associated DVA, which is pointed with a yellow arrow. And this is another case of a 50-year-old female. She had also acute headaches and troubles of consciousness. And then she had a CT, which revealed a subarachnoid hemorrhage. So she was WFNS grade 2, Fisher 4. And she had this distal pica aneurysm. So so she had a lot of blood in the fourth ventricle, and this is the angiogram. And after discussion with our neurological colleagues, we went for surgical clipping of this pica aneurysm. So it was a unilateral CSFM approach here, the pica. So we had the temporary clipping. So, and this was a control with the Doppler and the shrinkage of the aneurysm. And this was the intraoperative control. And the post-operative CTA. And the MRI that was done at 6 months after surgery. So just 2 more cases to show that this approach is also nice and adequate for vascular lesions as cavernomas and some rare, very rare aneurysms of the pica that are not treated by endovascular therapy.
Thank you so much, Jan. Very interesting, and as you showed, it's very important to master this approach for a variety of pathology, not only tumoral ones, but also vascular ones. If you can maybe stop to share your screen, and is there any other comment or question from one of you? Please, it's just a moment, the right moment. Henri, Eckhart, or Martin, or Jan?
It's also our standard approach to the pica. It's more a subtonsillar approach than a true velotalar approach, because you basically lift the tonsil, open the recess, and I think it's the best approach. We use that subtonsillar approach also for pathologies alongside the vertebral artery, like tumors, meningiomas. You can use it nicely for tumors in the jugular foramen. And the group of Marcos Tatajiba also published on the subtonsillar approach for various different pathologies. And I think that is an underused approach. You can solve with this midline subtonsillar approach many lateral pathologies in a more elegant way than during a retrosigmoid extended approach downwards, where you have to cut through the muscles and have to skeletonize C1 from lateral and do a hemilaminectomy C1 to get there from lateral. And from looking from above, subtonsillar approach, you can get there with much less trauma to the tissues.
Yeah,
I don't know if you agree, Jan Frederick.
Yeah, even for some foramen magnum meningiomas, you can use it nicely. That's true.
So thank you so much to all of you to participate to this very beautiful webinar. I think you have demonstrated the interest of this Telovelar approach, a very atraumatic one, to reach a variety of regions, to handle a variety of pathologies. Thank you so much, and it will be for me a pleasure to meet you again for the last webinar, I will say, of the season. It is the 3rd week of June. We have still to define the topic, but I'm sure that it will be very interesting. So it will be my pleasure to meet you in 4 weeks to discuss again a very interesting topic of our discipline. So thank you again.
Bye-bye.
It was a great pleasure.
All right.
See you soon. Take care in the meantime.
Have a nice weekend, evening.
Already weekend, not yet. But
Okay, bye-bye, guys.